So next move on to the autoimmune disorders. Now we had seen about tolerance. So whenever this tolerance is lost, so it will result in autoimmune disorders. So we have various genetic and environmental factors contributing to this autoimmune disorders. Let's start with the genetic factors. Firstly, any defective tolerance will result in autoimmune disorders. Then certain HLA association, susceptibility, we have already mentioned about the examples of that. So those people are specifically prone for developing certain autoimmune diseases, like HLA-DQ was susceptible for SLE, right? Then we have some other genes also like PTPN22, NOD2, CD25 and interleukin 23 receptor polymorphisms, which can result in certain specific diseases. So these are very important MCQs again. Out of this, the PTPN22 is the most common mutation for autoimmune diseases. So PTPN22, it is going to result in diabetes mellitus, multiple sclerosis, all this. NOD2 polymorphisms are going to result in Crohn's disease, which is a inflammatory bowel disease, right? In CD25 polymorphisms, already we had mentioned, it is multiple sclerosis. Interleukin 23 receptor, here again, it is going to be inflammatory bowel disease, IBD, okay? So in environmental factors, we have certain factors like molecular mimicry. So molecular mimicry, I've already mentioned. Here it was in rheumatic fever. Cross-reactive antibodies are going to attack the host tissues. These cross-reactive antibodies were formed against the streptococcal antigens actually. So other than that, we have upregulation of the co-stimulatory molecules on the antigen presenting cells, or polyclonal B cell activation as in the case of Epstein-Barr viruses, or production of new antigens, or even tissue injury. So what happens in tissue injury is that the normal nuclear antigens are going to be exposed. So nuclear antigens are usually enclosed inside the cell. So with tissue injury, the nuclear antigens are going to be exposed and they are to the external environment. So there is going to be production of anti-nuclear antibodies, which forms the basis of many autoimmune disorders, especially SLE. Okay. So anti-nuclear antibodies are being formed because of tissue injury. Also, there is something called as epitope spreading. So what happens is, whenever there is tissue injury, not only the cell, the surrounding cells are also going to be affected, meaning furthermore the amplified response is going to happen. So when this cell is going to be affected, it's going to affect the nearby cells also. So in the nearby cells, nucleus is also going to be exposed, so it is going to cause furthermore reaction. So this is called as epitope spreading. This is again one of the main causes of this autoimmune disorders. So let's see about the various autoimmune disorders, starting from SLE. So SLE, I already mentioned, it is both type 2 and type 3 hypersensitivity reaction. Out of this, type 3 is the most important response. So it is usually most of the autoimmune disorders are mostly common in middle-aged females. There are exceptions definitely, but most commonly in middle-aged females. So HLA-DQ was associated with systemic lupus erythematosus. Apart from that, certain drugs like sulfonamides, hydralazine, isoniazid, and procainamide. So these drugs, we usually call it as ship drugs, right? So ship drugs are again going to cause SLE, which is a type of SLE called as drug-induced systemic lupus erythematosus. So there are also, we already saw about neutrophil extracellular traps, right? So what happens in that? The nuclear material of the neutrophils are being thrown out of the cell so that it can capture the bacteria and contain the infection, right? So whenever this nuclear antigens of this neutrophils are being exposed, they are going to result in the formation of anti-nuclear antibodies. ANAs are anti-nuclear antibodies. Same thing, UV exposure. So these SLEs are main risk factor for this is UV radiation. So UV radiation is usually attacking the DNA. So nuclear damage is going to be present. That will again expose nuclear antigens, leading to the formation of anti-nuclear antibodies. So anti-nuclear antibodies are most commonly seen in SLEs. So clinical criteria to diagnose this SLEs are, you must have at least 4 out of this 11 features. So starting with malar rash. So but it is also called as butterfly rash. So malar region, that is the cheek region here. So like a butterfly distribution, there is going to be a rash which is going to be photosensitive. So whenever they go in sun or go out in sunlight, it is going to be the reaction is going to be increased. This rash is going to be much more prominent. So malar rash, then we have a discoid rash, which is appear disc shaped. So discoid rash. Then alopecia. This type of alopecia is going to be non-scarring kind of alopecia. Then ulcers, various ulcers, mucosal ulcers, which is painless ulcers. Then arthritis, which is non-erosive arthritis. Okay, it is not going to erode the joint or cause deformity. It's a non-erosive arthritis. Then various serositis like pleuritis, pericarditis. Okay, those kind of serositis is going to be present. Then renal manifestations. So in renal also we'll be studying this in detail. It is called as lupus nephritis. We have 5 subclasses of it. Okay, sorry, 6 subclasses of it. So lupus nephritis is going to be present. Then neurological symptoms, we are going to have psychosis, seizures, coma as well. So usually they present with psychosis. Then hemolytic anemia, then leukopenia, then thrombocytopenia. So all the blood cells are going to be decreased, resulting in pancytopenia. So all of this clinical features can be present in SLE. Out of this, at least 4 must be present to call it as SLE. So this is the malar rash I was talking about, having a peculiar butterfly kind of an arrangement here. The discoid rash is having this disc-shaped appearance. Then in lupus nephritis, that is in the kidney, if you see the glomerulus, it is going to produce a characteristic lesion called as the wire loop lesions. So these wire loop lesions are nothing but subendothelial immune complex deposit. So it is a type 3 type of hypersensitivity reaction, right? So this immune complexes which are formed are going to deposit in the subendothelial location, forming this wire loop lesion. So in the capillaries, if you see here, it is going to have this characteristic appearance, darkened pink appearance, which are called as wire loop lesions. It is going to be seen in class 3, 4 and 5 of lupus nephritis. I told 6 classes are there, right? So out of this, it is going to be present in class 3, 4 and 5, but most commonly in type 4, which is called as the diffuse proliferative lupus nephritis class. Okay. So as the amount of this wire loop lesions are going to decide the severity of the disease. So the more the amount of wire loop lesions, more is the severity of the disease. So moving on to the immunological criteria of SLE, we are going to test the antibodies, various antibodies. So the anti-nuclear antibodies which are formed. No? So these are the most common and the most sensitive antibodies as well. And anti-Smith antibodies is anti-SM. It's going to be the most specific antibody. While both specific and sensitive, it is going to be anti-double-stranded DNA antibodies against the nuclear antigen, which is anti-double-stranded DNA antibody, both sensitive and specific. Apart from that, we also have anti-phospholipid antibodies, then direct Coombs test, and because it is an immune complex mediated disorder, here it is going to cause the decrease in the immune complex like C3 and C4 complements. So these anti-nuclear antibodies, if you see, you can visualize it under the indirect immunofluorescence. Under indirect immunofluorescence, they are going to have peculiar patterns. So any of this can be asked as image-based questions. So this first pattern is the homogeneous pattern. So this first pattern is going to be called as the homogeneous pattern, in which the entire nucleus is going to be stained like this. So this kind of pattern is the homogeneous pattern, specifically seen in SLE. Then the next one is the speckled pattern. If you see inside the nucleus, you are going to see some dot-like things. So this is the speckled pattern, which is the most common pattern actually, but it is very least specific because it is also seen in other conditions like Jorgen syndrome. Then we have the nucleolar pattern. So inside the nucleus, you have darker dots like this, which is going to be the nuclear pattern, which is again seen in SLE and also in systemic sclerosis here. Then there is a peripheral rim pattern, which is just highlighting the nuclear envelope. So this is seen in SLE again. Then we have a centromere pattern, again dot kind of arrangement only. But if you see in here in the speckled pattern, you are going to see these dots as empty spaces. But in centromere pattern, you are going to see these dots as dots. The surrounding part is also green. These dots is also green. While this in speckled pattern, the dots are going to be empty. Okay. So this pattern, centromere pattern, is going to be seen in systemic sclerosis, especially in the localized form of systemic sclerosis, which is the CREST syndrome. We'll be seeing that later. So let's see. Homogeneous pattern, peripheral rim pattern, and then nuclear pattern are going to be seen in SLE. Apart from that, speckled pattern also, which is the most common pattern in SLE, but least specific. So let's see about the other antibodies also. So anti-Rho antibody. So anti-Rho antibody in SLE is going to be associated with Neonatal lupus. So neonatal lupus is going to present with congenital heart block. Okay. So neonatal lupus and also antibodies are going to be associated with shrinking lung syndrome. So shrinking lung syndrome is another feature of SLE only. So in SLE, antibodies can be present. So here it is going to be associated with neonatal lupus and also shrinking lung syndrome. Then we have anti-ribosomal P antibodies. So this is going to be associated with psychosis in SLE. So P for P. Okay. Then we have anti-beta 2 glycoprotein antibodies, which are going to be associated with anti-phospholipid antibody syndrome called as APLA syndrome. So APLA syndrome, we have various antibodies formation, 3 antibodies basically, anti-beta 2 glycoprotein antibodies, lupus anticoagulant, and also anti-cardiolipin antibody. Out of this, anti-beta 2 glycoprotein antibody is going to be commonly associated with SLE also. So in in APLA syndrome, we have primary and secondary APLA. The secondary APLA is going to be most commonly associated with SLE, and therein we are going to see this anti-beta 2 glycoprotein antibody. We have antihistone antibodies which are present in drug-induced lupus. So in drug-induced lupus, we are going to have this antihistone antibodies. So all of these antibodies and these patterns along with the image-based questions are very, very important MCQs. So let's see other features which are seen in SLE. So in lung, most commonly we see is a pleuritis, actually a pleuritis, serositis, right? One of the serositis is pleuritis. So pleuritis we see. Then shrinking lung syndrome. This was associated with the anti-Rho antibody. Then in heart, we saw Liebman-Sachs endocarditis. So it's a type of endocarditis. So if you put it in short form, it is LSE. So it looks like SLE, right? So if you rejumble it, it is going to cause LSE. In this, the vegetations are going to be present on both the upper surface and the lower surface of the cusps, but more on the lower surface than the upper surface. So here again, LS is present. So LS, lower surface, is the most common place where you see the vegetations in Liebman-Sachs endocarditis. Then in spleen, you are going to see onion skinning around the splenic vessels. Then musculoskeletal problems like muscle weakness is going to be the most common presentation in the SLE. So about APLA, I've already told here that is antibodies are going to be present against the phospholipid membrane antigens. So, and in this, the characteristic feature will be formation of multiple thrombus. So, because of this thrombus, these unusual occasions you'll get thrombus formation like Budd-Chiari syndrome. So, Budd-Chiari syndrome is hepatic vein thrombosis. So, in hepatic vein thrombosis, it's not a usually we do see, right? So, whenever you see Budd-Chiari syndrome, you'll have to rule out other causes like APLA syndrome, PNH, which is paroxysmal nocturnal hematuria, hemoglobinuria. So PNH and APLA are very important causes of Budd-Chiari syndrome. So unusual multiple thrombosis like DVT, stroke, Budd-Chiari syndrome, and also recurrent abortions will be given in a history. So in a young female, they'll present with recurrent abortions because in the fetal vessel, there is going to be lots of this thrombus formation, which will result in the fetal blood compromise. So without this fetal blood supply, the fetus is going to die, resulting in abortion. So already I mentioned 3 antibodies mainly we see in APLA syndrome: anti-beta 2 glycoprotein antibody, anti-cardiolipin antibody, and lupus anticoagulant. So out of this anti-beta 2 glycoprotein antibody, we saw it in SLE-associated lupus, SLE-associated APLA. Then anti-cardiolipin antibody. Because of this anti-cardiolipin antibody, it is going to give a false positive VDRL test. So VDRL test is a test we use for syphilis detection, but it is going to use this cardiolipin antigen for the test actually. So since this APLA syndrome has anti-cardiolipin antibody, this they are going to give a false positive VDRL as well. Then lupus anticoagulant. Okay, so this, because of this, there is going to be elevated APTT as well. Okay, that we'll be seeing when we are reading blood chapter. So how do we diagnose this APLA syndrome is we'll have to use the diluted Russell Viper venom test. So this is the diagnostic test to confirm APLA. So a word about drug-induced lupus. So already I mentioned drug-induced, it is associated with histone, anti-histone antibodies, right? And the drugs will be usually SHIP drugs. SHIP drugs is sulfonamides, hydralazine, isoniazid, and procainamide. So SHIP drugs history can be there, and it is associated with anti-histone antibodies. And how does it differ from SLE is that Here, you don't usually get CNS and renal symptoms. So in SLE, we had lupus nephritis and psychosis symptoms. Like those symptoms will not be present in this drug-induced lupus. So treatment is whenever you sees the stoppage of the drug, it can revert back to normal. So now let's see about the second autoimmune disorder, which is Sjogren's syndrome. So Sjogren's syndrome can be again primary and secondary. It is also called as Zika syndrome because of its manifestation. So in the primary Zika syndrome, it usually affects the salivary gland and the lacrimal gland. There, it is going to cause lots of inflammation and fibrosis. So the salivary gland and lacrimal gland, if they undergo fibrosis, they cannot produce their secretions. So it will result in the dryness. So under glandular pathology, so they'll cause xerostomia, which is dry mouth, because it is going to affect the salivary gland. Salivary gland fibrosis is going to happen, resulting in xerostomia. Same for lacrimal gland, fibrosis and inflammation is going to cause keratoconjunctivitis Zika. So dryness of the eye is keratoconjunctivitis Zika. So extraglandular manifestations, it is usually presenting with extraglandular manifestations more than the glandular presentation. Most common presentation of this Sjogren's syndrome is actually arthritis. Okay, most common is arthritis, and they have an increased risk of developing marginal zone lymphoma. So any chronic inflammation is present. So in the salivary gland and parotid, if you see, there will be lots of inflammation, and they are prone for developing lymphomas at these unusual sites, which is a marginal zone lymphoma. Apart from that, any kind of other fibrosis like pulmonary fibrosis, neuropathy can also be seen in these patients. Secondary Sjogren's is going to be associated with other autoimmune disorders, mainly rheumatoid arthritis and SLE, out of which rheumatoid arthritis is the most common association with Sjogren's. So how do you diagnose? We have to check for antibodies again. So in this again, you are going to have the anti-Rho antibodies. So anti-Rho antibodies is also called as anti-SSA antibodies. So they are going to be most sensitive antibodies, while anti-La antibodies are also called as anti-SSA. SS stands for Sjogren's syndrome. So anti-SSB antibodies are going to be the most specific. Why? Because Rho antibodies we also saw in SLE, right? SLE, shrinking lung syndrome, and lupus, neonatal lupus. So both of this is also going to have anti-Rho. So this cannot be specific for Sjogren's. So anti-La is more specific, while anti-Rho is going to be more sensitive. So how do you confirm the diagnosis? If you do a lip biopsy, which is usually the investigation of choice actually. So if you do a lip biopsy, you are going to see lots of minor salivary glands in the lip. So there you are going to have lots of chronic inflammatory cells along with fibrosis. This is the classical findings which you see in a Sjogren's syndrome. So moving on to the third autoimmune disease, which is systemic sclerosis. So sclerosis, as the name suggests, there is going to be some fibrosis associated. So sclerosis means collagen deposition. Collagen is going to be deposited because of fibroblasts. So there is going to be fibrosis here. So fibrosis will happen because of growth factors like PDGF and TGF beta. These will result in inducing the fibrosis. So the hallmark of systemic sclerosis, if they ask, it is going to be microvascular injury. So small vessels are going to be affected in this disease, which is the central role for the pathogenesis of systemic sclerosis, resulting in fibrosis. So microvascular injury is the hallmark of systemic sclerosis. Here again, we have two types of systemic sclerosis, limited type and the systemic type. Limited type is the one which is associated with the anti-centromere antibody. Remember in the immunofluorescence diagram, we saw anti-centromere antibody. So this is the most important antibody here. Limited because it is going to be limited to the skin usually. The patients usually have skin manifestation. They have fibrosed skin. So skin fibrosis will be there, and later on, as the disease progresses only, they'll have a visceral manifestation. And a part of this limited systemic sclerosis is called as the CREST syndrome. It is a mnemonic actually. So CREST syndrome stands for calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. So this CREST syndrome can be given in the history, and they might ask for the antibody associated. So you'll have to choose anti-centromere antibody here. So in diffuse systemic sclerosis, we are going to have both skin and early visceral manifestations. So many viscera can be involved. Mostly it is the lung viscera which is involved, causing lung fibrosis. Apart from that, esophageal fibrosis. So the patient will complain of dysphagia. The motility will be affected. Then GIT, heart again. So heart you can cause the heart will not be able to pump properly because of the fibrosis. Kidney again. So here it is going to be associated with topoisomerase antibody, which is a very specific antibody. So more specific antibody for systemic sclerosis is anti-topoisomerase antibody. It is also called as the anti-systemic sclerosis S70 antibody, anti-SCL70 antibody. Okay, then systemic sclerosis, if you see here again, you can see anti-nuclear antibodies, which is the most sensitive actually. Most specific was anti-topoisomerase seen in diffuse, while most sensitive was anti-nuclear antibodies only. Apart from that, we can also see anti-RNA polymerase 3 antibodies in systemic sclerosis, which will have an acute presentation. Whenever this anti-RNA polymerase 3 antibodies are present, they'll have an acute presentation and an increased risk of cancer and renal crisis. So R for R, renal and increased risk of cancer. So next, moving on to the mixed connective tissue disorder. Here, as the name suggests, there is going to be multiple disorders associated. So usually it is SLE associated with systemic sclerosis along with polymyositis. This combination will be seen in mixed connective tissue disorder. So here the antibody associated will be anti-U1 ribonucleoprotein antibody. Okay, anti-U1 ribonucleoprotein antibody. So here they have very good response to steroids. Then the next autoimmune disorder will be a inflammatory myopathy. So we have three basic types of inflammatory myopathies. So as the name suggests, there is going to be inflammation. Myo means muscle. So because of the inflammation, there is going to be some muscle disorder. So dermatomyositis, polymyositis and inclusion body myositis is there. So first we'll see about dermatomyositis. So as the name suggests, derma means skin, myo means muscle, itis means inflammation. So inflammation in the skin and muscle is going to be present. Okay, so in the skin, it is going to have classical manifestations called as heliotrope rash. This is a rash which is present around the eyes. It is giving a lilac colored skin around the eyes, which is called as a heliotrope rash. Then we have Gottron's papule, which is going to be present on the knuckles. Then we have mechanic's hands, which is nothing but rough hands present on the fingertips. Then in the muscle, we are going to have inflammation. So lots of inflammation, which is going to be perifascicular. So around the fascicles of the muscle, you are going to have lots of inflammation, and this inflammation will be composed of the CD4 positive T cells, and it will result in the atrophy and the destruction of the muscles. Okay, so perifascicular inflammation and atrophy is the characteristic feature we see in dermatomyositis. So here again we are seeing specific antibodies. I know it is too much of antibodies, but you need to remember all of this antibodies. So anti-Jo1 antibody is going to be associated with the mechanic's hands, while anti-Mi2 antibodies will be associated with the Gottron's papules and also the heliotrope rash. When anti-P155 and P140 antibody is going to be associated with the juvenile form of this disease. Okay, so usually in the muscle, they are going to produce proximal muscle weakness. So proximal muscles are going to be affected, causing weakness. So this perifascicular atrophy is the characteristic finding we see in dermatomyositis. Coming to polymyositis, which was again a part of the mixed connective tissue disorder, right? So here, as the name suggests, poly means multiple, myo means muscle, itis means inflammation. So multiple muscles are going to be associated with inflammation, resulting in disorder of the muscle. So here there is no skin involvement. Here again, like dermatomyositis, there is going to be proximal muscle weakness only. And in the muscle biopsy, if you see, there is going to be endomysial inflammation. So inside the fascicle, inside the muscle fiber itself, there is going to be inflammation. Here it is CD8 positive T cells, while it was CD4 positive T cells in dermatomyositis. Coming to inclusion body myositis, so as the name suggests, there is going to be some kind of inclusion present in the muscle, and there will be inflammation. And this IBM is the most common type of myositis seen in the elderly. And here you are going to have distal muscle weakness. So the first two were proximal muscle weakness, while IBM is going to be a distal muscle weakness. So the patients will have difficulty in buttoning their shirts, combing their hair. So this kind of difficulty will be there. So here it is going to be associated with anti-5' nucleotidase 1A antibody. Okay. And in the muscle biopsy, as the name suggests, there is going to be presence of inclusions which are going to be termed as rimmed vacuoles. So rimmed vacuoles are present in the muscle. So let's see the image based questions are related to this. So this first image, around the eyes, if you see, there is a lilac colored rash called as the heliotrap rash. Then we have this around these knuckles, we have this skin thickening kind of thing. This is called as the Gottran's papules. Then here at the fingertips, you are having some thickened skin called as the mechanic's hands. All of this were manifestations of the dermatomyositis. So in dermatomyositis, in muscle biopsy, what did we see? Perifascicular atrophy and inflammation. So this entire thing is a fascicle. This entire thing is a fascicle. So at the edges of the fascicle, you are going to see this kind of inflammation composed of CD4 positive T cells, characteristic of dermatomyositis. While in the second image here, if you see, this is, and this inside this, all of this is our muscle fibers. So in between the muscle fibers, you are going to see this kind of inflammation called as endomysial inflammation, characteristic of polymyositis. Here it is CD8 positive T cells. Okay, this is very, very important MCQ. Then inclusion body. So if you see in H&D stain here, there is going to be some kind of rimmed appearance. This is the inclusions which are going to be appearing like a rimmed kind of vacuoles, seen in special stain called as Gomery's trichrome stain. So this classical image based questions have been asked before in exams as well. So inclusion body myositis can be seen more clearly in a Gomery's trichrome stain. So next, moving on to the next autoimmune disorder, which is IgG4 related disease. So it is an upcoming disease actually. Previously, whatever diseases were thought, they are actually combining under this IgG4 related disease. Multiple diseases actually come under this spectrum. So in this, we are going to have lots of tissue infiltrate of IgG4 positive plasma cells along with lymphocytes. Okay. So as the name suggests, IgG4 type of plasma cells are going to infiltrate the tissues. So how do you identify this? If you measure the serum levels of IgG4, they are going to be quite elevated in these patients. Then there is going to be in the biopsy, if you see, there is going to be a type of storiform fibrosis. Storiform is nothing but they are going to be arranged like a wheel or spokes of a wheel. So this kind of a wheel kind of arrangement will be called as storiform arrangement. So that kind of fibrosis will be seen. So storiform fibrosis, then obliterative phlebitis. So the vessel is there. Around the vessel, there is going to be inflammation and there is going to be obliteration of the vessel. This is called as obliterative phlebitis. Then in the tissue, we are going to see lots of inflammatory cells which are composed of this plasma cells which are positive for IgG4 along with lymphocytes. This is the classical image of IgG4 diseases. The storiform fibrosis with obliterative phlebitis and increased tissue infiltrates of IgG4 positive plasma cells and lymphocytes, along with elevated serum IgG4 levels. Classical findings of IgG4 disease. So what are the diseases under this spectrum? So Mikulicz syndrome. Mikulicz syndrome is nothing but involvement of the salivary gland and lacrimal gland. So Zika syndrome we read, right, in Sjogren's. So the same thing is called as the Mikulicz syndrome. Along with that, Riedel's thyroiditis, idiopathic retroperitoneal fibrosis, then autoimmune pancreatitis type 1. Only type 1 is IgG4, not type 2. Okay. So type 1 autoimmune pancreatitis, then inflammatory pseudotumors. All of this come under the constellation of IgG4 related diseases. So classically in the question, you will be given a history of a mass. So it will appear like a mass lesion. So the clinician will actually think it as a tumor and they will take out the specimen and send it to you. And if you see in the biopsy, you are going to see the classical findings of IgG4. So this mass lesion is the classical feature of a IgG4 related disease which mimics the tumor. So since it is a autoimmune disorder and directed against the immunoglobulins, IgG4 plasma cells. So you can give rituximab treatment, which is going to be directed against the anti-CD20. So CD20 is going to be expressed by B cells, right? So anti-CD20. So you can use this anti-CD20 rituximab to stop the production of this B cells which are forming in the plasma cells. Okay.